Part 5. Physical Health and Medical Management, covering the essentials, paediatrics, and specialist mental health hospital.
One of the challenges with looking after somebody with an eating disorder is that they start often talking about things in a way that makes no sense. For instance, it makes no sense to try and avoid eating when that is the thing you need to do to stay alive. It makes no sense to calorie count and then restrict the amount of calories you have. Sometimes what I think is helpful is to try and have this conversation very openly and clearly about what it is that they're actually scared of and what that actually means. Unfortunately, a lot of people's understanding of the science is pretty poor. And so I ask most of the people I look after, do they know what a calorie is? And we have a conversation about energy. We have a conversation about nutrition. We have a conversation about what their body actually needs. And I try to talk about the fact that they wouldn't have expected to come to see me in a car that had no petrol, and that nobody had checked the tire pressures or the oil or hadn't had his MOT. They wouldn't expect to come to me in a car that was driven on the wrong side of the road or didn't have brakes checked. And that actually a lot of what the eating disorder is doing to them is stopping them from looking after some really, really basic requirements that they need. Furthermore, with the energy side of things, we have a conversation about how much energy a human being actually needs. How much energy, for instance, do you need when you weigh so much just to lie in bed and do absolutely nothing? How much more energy do you need to go through puberty? How much more energy do you need to go for a run for an hour, or cycle, or go to school? And actually, some of the things that we need to talk about are some very, very basic scientific principles to help the young people to understand what's going on in their bodies. Because what they have to understand is that many of the physical symptoms that they have are a direct consequence of what is happening to their body because it's being starved to death. If you are malnourished, there are consequences for your body, and those consequences might be manifest in the fact that you stop having periods if you're a girl. They might be manifest in the fact that you start feeling very dizzy, or you have muscle aches, or you feel breathless when you exercise, or you're not able to pay attention in class, or you constantly feel sick. Understanding the connection between the science of what's going on in their bodies and how that's manifesting in them is part of helping them to understand the changes that need to happen. But it's also a really important part of helping them to understand why getting physically healthy has to come before therapy. Because actually, if you can't think straight, the best therapist in the world is not going to help you. And my job is to make sure that you're physically healthy enough to think straight. And so families often come to us wanting therapy, wanting guidance, wanting all sorts of things, but actually what their child needs is nutrition, and good nutrition, healthy nutrition. I say to the young people, I have no interest in making you fat. I have no interest in doing anything other than helping get your body back into equilibrium so that you can work out who you want to be and how you're going to do that and live your best life. And I think that conversation starts with science and then at some point transfers across to psychology. And that's why I have psychology colleagues to pick up the conversation after me. I've previously mentioned that we know what tends to work and what tends not to work in young people with eating disorders. We are very fortunate to have some excellent guidelines that have been written both for adults with eating disorder and for young people with eating disorders. The Marzipan guidelines have been around for some time. The guidelines for children are being updated fairly soon. And what they help professionals to do is to know what is most likely to be the safest, most effective way of looking after a young person. Be that their physical health because they're acutely unwell and on a pediatric ward, or whether they can be in the community but need additional support. all pediatric units, all doctors, nurses, dietitians looking after young people with eating disorders should be using the Modality Plan guidelines. We will all have our own versions of how we use those guidelines, but they should all be based around these guidelines. And they give a very good common point for us to refer back to try and make sure that we're all doing the best thing for the young people we look after. The physical health of a young person with an eating disorder may be a pressing, acute problem for them, requiring an inpatient stay in hospital. That's actually pretty unusual. Most young people with eating disorders, particularly if they've been picked up reasonably early by their parents or by somebody at a youth group or at school or a social worker or a GP, if those young people are referred into an eating disorders team in a timely way, often are unwell from a medical point of view, but not so unwell that they need to be in hospital. It's really important that they have access to the right medical assessments, whether those are in primary care by the GP or whether they need to come up to hospital to see a paediatrician, and sometimes they will need to be admitted to hospital. But equally, we know that eating disorders are disorders that affect young people where they live and in their schools and in their homes, and that is the best place to try and start to change things. And we work really hard with our colleagues to try and make sure that we keep young people in the community with the best support that we can, but that equally we make sure that they're physically healthy enough to be able to work with that support. This requires really good communication. It requires people who understand eating disorders and understand their role and are prepared to talk to each other and work in complicated, sometimes unusual ways to try and work out what is going to be best for that young person and their family. If a young person does need to come into hospital with an eating disorder, there are really a few key things that we need to get right. First of all, they are medically sick, and therefore we need to make sure that the diagnosis is correct. It might be that they need other tests to rule out other physical illnesses. If we believe that this is an eating disorder, this is a very concrete way of impressing upon the young person and supporting the family in coming to terms with the fact that this is the diagnosis. And that's a really important thing that we can do in hospital, is supporting our eating disorders team colleagues in establishing what the diagnosis is and what the basic plan is going forward. The third reason why they might come into hospital is because we need to start building those relationships. We need to start building a common framework of reference for us all to work together. And the fourth, and sometimes the scariest reason for coming into hospital, is this thing called refeeding syndrome. We know that if a human being is starved for a period of time, they can then have a very unusual and potentially life-threatening reaction to refeeding. And this is called refeeding syndrome. I imagine it a little bit like a derelict building that was being built, and halfway through it being built, the builders had to go away, and the framework started to rust, and all the building materials started being stolen or taken away. And then the builders returned and wanted to start building again. But unfortunately, because they don't have the raw materials, actually this can go really, really badly wrong. And so we monitor the young people very closely over the first week or so of their admission to keep an eye on their physical health and the salts and their blood tests to see if they need any additional supplementation, to make sure that if they do have refeeding syndrome, we can help them get through this and then nurture them to the point where they can start increasing their calorie intake, increasing the amount of nutrition they're receiving, and start becoming healthier and aiming towards weight restitution. It is sometimes, unfortunately, the case that a young person is so unwell because of their eating disorder that their needs can't be met in the community. In other words, the support that they need to be able to eat and drink enough to stay healthy and get weight restitution and start moving forward with their lives is support that cannot be delivered in the community. Happily, this is quite an unusual event, and happily, most young people will never need to go to a specialist eating disorder unit or an inpatient psychiatric unit. There are, however, a small number of young people for whom that support in the community is not going to be enough. The clinicians who are looking after that young person will have to have a very difficult conversation amongst themselves and with the family and with the young person, and decide that what that young person is going to need is a period of inpatient stay. This is not a decision that they'll come to lightly or one individual person will decide, but it is a collaborative decision made by the whole team in that young person's best interest.
We've now completed the end of Module 5, and before starting the next module, please give some feedback by clicking on the QR code below.